we might make a start. So welcome everyone to the Benchmark Group Immunisation Update with Western Vic PHN. Just before we start, I would like to pay my respects and acknowledge the traditional custodians upon the land of which we meet this evening, and pay our respects to elders past, present and emerging. My name's Sarah Drew. I'm the Education Manager with the Benchmark Group and would like to welcome you all this evening. Just before we start, I'd also like to thank our sponsors for this evening's events. So both GSK and Pfizer. Without their sponsorship, the event this evening would not be possible. A little bit of housekeeping before we start. Tonight's presentation is being recorded and will be available to participants in the coming days if you'd like to revisit the information provided this evening. I am going to ask, as everyone enters, you will be on mute. You will notice, as we're in the Zoom education platform, not strictly webinars, that you are able to unmute yourself. However, in saying that, I do request that everyone stays on mute. And if you do have a question that you'd like to pose to one of the speakers this evening, that you would please just pop it into the chat box. And then we will moderate those questions, and during chat time, we will present those to the speakers for this evening to respond for you. At the end of tonight's webinar, you will receive a feedback survey. We ask that you complete that survey in order to look at presenting further webinars in the region based on the future topics that you would be interested in. You will also have access to your certificate of attendance through your IQ portal once we close tonight's meeting. So tonight we have a number of speakers with us. We have the Western Vic PHN. We're then going to have Dr. Ginny Mansberg talk us through a COVID update as well as Influenza 2020. Dr. Kyle Wilcox will then take us through a pneumococcal vaccine update. We'll have some more time for some questions, and then we're going to close out after that. So to get tonight underway, I'm going to hand over to Cherie Rayner. Cherie Rayner is one of our senior facilitators with the Benchmark Group, and she's going to introduce you to our speakers tonight and take you through the event. Have a great night.
Good evening, everyone. It's great to have you with us. Tonight, I'm going to start by introducing you to our speakers. The first of them being Dr. Ginny Mansberg. You probably all recognise Dr. Ginny. She comes to us from the University of Notre Dame in Sydney. Probably recognise her from television, Channel 7 Sunrise, Embarrassing Bodies, Channel 9 and SBS, Medicine or Myth. And things you can't talk about on TV, on Audible, and Drive Time Medical. And she's also a board member for the Immunisation Coalition and co-author. And then we've got Dr. Kyle Wilcox from Inner North Medical Clinic. He's a local GP and he's worked extensively in a few roles in the Northern Territory, rural northern New South Wales and Victoria in a number of roles. Previously worked in East Timor. He's got extensive experience in paediatrics and travel medicine and a master's in public health and tropical medicine from James Cook University. So a lot of experience he brings with him tonight. Then I'd like to introduce you all to Claire Dagley. She's the Senior Manager with Western Victoria PHN Network. And last but not least, Alison Elliott, the Coordinator of Immunisation Warrnambool for the City Council of Warrnambool. So welcome you all. It's lovely to have you all with us. So tonight we're going to start with Dr. Jenny, I think. Would you like to get us started?
Claire is first.
Claire's going to start first. Claire.
Thanks very much, Cherie. So good evening, everyone. As Cherie mentioned, my name's Claire Dagley, and I'm the Senior Manager at West Vic PHN for the Great South Coast region. I'm also the immunisation portfolio holder for Western Victoria PHN, which is why I've been asked to present to you this evening. So I thought I would begin this presentation by providing some insight into the work that Westvic PHN do in the immunisation space, as well as provide some local context for immunisation in the Western Victoria region. Immunisation is an important part of the work Western Vic PHN do and is a key element of our preventative health strategy. We work with immunisers across our region to provide information and resources for delivering quality and safe vaccination services for protecting individuals and communities from vaccine preventable diseases. A significant part of our role is to increase childhood vaccination rates for children up to the age of 5 years old. Due to our significant focus on childhood vaccination, in coming slides I will provide you with detail on coverage rates for children in Western Victoria across the 1-year-old, 2-year-old and 5-year-old cohorts. A key priority for Westvic PHN is to support our local immunisers to actively work with patients and embed systems to ensure all children are followed up with timely vaccinations as per the National Immunisation Program. There are 2 key reports that our immunisation officers use in order to support high rates of immunisation coverage in children up to the age of 5. These reports are the Australian Immunisation Register, or AIR 11A report, as well as the DHHS 11A project report. Through using information from both of these reports, our immunisation officers are able to identify any discrepancies in the data, as well as detect children requiring immunisations before the AIR age cut-off date. Our immunisation officers will then contact local immunisers directly for support and follow-up of these children. It is important to note, however, that the PHN immunisation officers are not available for general calls. We encourage all requests for clinical advice and general support to be directed to the DHHS Immunisation Support Line and the DHHS Immunisation website. So in addition to the work that our PHN undertakes to support childhood immunisation in our region, our PHN also provides opportunities for local immunisers to access education and training. This evening's webinar is an example of the relationship that our PHN has developed with Benchmark. Benchmark has been secured by our PHN to assist with the delivery of immunisation education across our region. The PHN also facilitates the delivery of the annual Managing Immunisation Emergencies workshop, as well as develops and delivers the annual Westvic PHN Immunisation Forum. Unfortunately, due to COVID, however, our annual immunisation forum dates have shifted and they're currently planned for October this year in both Ballarat and Geelong. I would, however, encourage those that are interested in attending to please continue to check our Westvic PHN website under the events link for further updates on this event. So to provide you with some local insight into, as well as an understanding of, the coverage rates for children up to the age of 5 in our region, I'll now cover off some local data. Children who are aged 5 years and under are divided into 3 cohorts: 1-year-old, 2-year-old and 5-year-old. So this is how the data will be grouped in the following graphs. And to provide a bit of background, AIR applies the following rules when they measure children for coverage reports. So a child in cohort 1, or what I tend to refer to as the 1-year-old cohort, must have had their 2, 4 and 6-month vaccines completed by their first birthday to be considered as fully covered in the 1-year-old cohort. A child in cohort 2, or the 2-year-old cohort, must have had their 2, 4, 6, 12 and 18-month vaccines completed by their second birthday. A child in cohort 3, or the 5-year-old cohort, must have received their 2, 4, 6, 12 and 18-month, as well as 4-year-old vaccines completed by their 5th birthday. And if we just jump back one slide quickly, Sarah, we'll just talk to the fact that we're very fortunate in Western Victoria to boast some of the highest rates of childhood immunisation in Australia. And this really is thanks to the dedication of our immunisers as well as the wider primary healthcare community. And as you can see here, Westvic PHN has 96.5% coverage rates for children aged 1 year old, which is actually above our target rate within Westvic PHN of 95% and well above both the state and national rates. And Westvic PHN has the highest childhood immunisation rates of any PHN in the 2-year-old cohort and the second highest in the 1 and 5-year-old age groups. So if we look here again at the the 2 and 5-year-old cohorts, we can see Westvic PHN rates sit higher than both Victorian and Australian rates, which really is quite fantastic to see. And just to clarify too, this data covers the calendar year, 1st of January 2019 through the 31st of January. And this data was released most recently in March, so these are the most current statistics that we have for our region. Now, I appreciate this is absolutely a very busy slide. However, it does provide a snapshot of immunisation coverage rates that are broken down by local government area. And all these local government areas are the ones that sit within our Westvic PHN region. It represents both the total percentage of children aged 1 year old that were fully immunised, as well as the percentage of Aboriginal and Torres Strait Islander children that were fully immunised in this cohort. You will notice that some LGAs have not recorded rates of immunisation for Aboriginal and Torres Strait Islander children in this cohort. If there is no data recorded for Aboriginal and Torres Strait Islanders, that is due to there being no children identified as Aboriginal and Torres Strait Islander in that group. This graph does show that there are a higher rate of vaccinations for Aboriginal and Torres Strait Islander children compared to the total number of children in areas where that data is available. And here again, we can see the rates of fully immunised children in the 2-year-old age group per local government area. And we can see that there are some relatively strong coverage rates across the region compared to both the state and national levels. There are, however, some exceptions. And here we have the 5-year-old age group statistics broken down by local government area. As we see here, which will also be reflected in further slides, the 5-year-old cohort typically has stronger coverage rates compared to the 2-year-old cohort. This is usually a result of immunisations being prompted because children require vaccinations to enable entry into kindergarten. So now we've got here just a quick snapshot of vaccination trends from 2020 through to 2017. And it is pleasing to see here that Westvic PHN rates have sat consistently above those of national rates for both the 1 and 2-year-old cohort. Here we have the 5-year-old cohort trends, and as before, higher rates of coverage are typically seen in this group compared to the 2-year-old cohort. And to provide a bit of explanation around this, the 2-year-old cohort is often quite a challenging one, and this is due to a number of influences in a parent's life when their child is around the age of 2. The parent might have returned to work, they might have had another child, or life has just been generally quite busy. This can result in immunisations being less likely to be followed up, or there is a delay in vaccinations being completed prior to the cut-off dates for this statistics. And if we have a look at the most current data provided from AIR, we can see that Aboriginal and Torres Strait Islander children within the Western Victoria PHN region have higher rates of full immunisation in each cohort when compared with the Victorian rates. And similar to the previous slides, and is what is reflective of a trend in the general population, we can note a drop in immunisation in the 2-year-old cohort, which then increases in the 5-year-old age group. And the last slide of local data I'll provide this evening shows the potentially preventable hospital admissions broken down by small geographic area. Unfortunately, this data is quite dated. However, these are tending to be the most current information that we have available. We can see here that all small geographic areas within the West Vic region have lower rates of potentially preventable hospitalisations for total vaccine preventable conditions when compared to the national rate.
We just had a question come in, Claire. What is the AIR cut-off date for that?
That would be Alison's, Alison Elliott. I work closely with at West Vic PHN, so she is very much the one who can answer all the data-driven questions.
Yeah.
So I'll hand over to Alison.
So to which cohort was the question in regard to?
That was in general.
In general, so, well, if you look at cohort 1, as Claire mentioned, cohort 1, they have to have had the 2, 4, 6 month immunisations by 12 months of age. For cohort 2, they have to have completed everything up to 6 months plus their 12 and 18 months by 2 years of age. And then by to be up to date in cohort 3, they have to have had all of the immunisations up to 4 years of age administered by 5 years of age. So basically 1 year, 2 year and 5 years are the cut-off dates for each cohort.
Yeah, okay.
Does that answer the question?
Thank you for that.
To the respondent? Yeah,
yeah.
Fantastic.
Thanks, Alison.
No problem.
So we can see that the Western Victoria region has some really excellent immunisation coverage rates. However, there are really a number of key things that we can do as local immunisers to support and enhance childhood immunisation coverage within our communities. So firstly, we can be proactive. Identify and contact patients that will soon be due or that we note are overdue for immunisations and encourage them to have these completed. You can also encourage patients to ensure their Medicare details are current, as AIR uses Medicare numbers as identifiers for their records. So incorrect information can compromise the accuracy of information that is generated in their reports. In addition to this, we recommend that immunisers cite a patient's Medicare card for their full name according to Medicare, as hyphenated names in particular can cause the creation of duplicated records on AIR. Additionally, clear and efficient internal processes can result in the timely and accurate entry of immunisation records into AIR, which can then in turn positively affect coverage rates. It is also important to notify AIR if a patient has moved overseas, as without doing so, AIR will continue to identify that patient as being under-immunised. Utilising key immunisation resources are valuable to ensuring that we're providing safe and quality immunisation services to our community. The Australian Immunisation Handbook is a highly valuable resource. However, please be sure to no longer use the paper-based versions of the handbook. The electronic versions provide the most current information, and the handbook has been recently released as a mobile application that can readily be downloaded onto devices. Also, appropriate cold chain management is essential, and DHHS provides resources, information, and a webinar in relation to cold chain management that may be of use. Cold chain management guidelines were updated in June 2019, so accessing this updated information is important. So to finish up this presentation, I thought I would provide some information on resources that you may be interested in accessing. DHHS provides an interactive infectious diseases surveillance report that you can break down per local government area for annual rates.
Thank you.
And also, I know COVID-19 will be covered by Ginny in her upcoming presentation. However, those interested in local government area data, DHHS provides an interactive surveillance of notifiable conditions report that tracks COVID-19 cases. So that's the end of my presentation, and I'd like to thank you all for your time this evening. I'd also like to thank you as our local immunisers for all the great work that you're doing for immunisation within the Western Victorian community.
Brilliant. Thank you so much, Claire. That was fantastic.
Cherie, we do just have one more question that's just come in, which is, are local immunisation clinics audited to show that they are recording properly onto the AIR? That might be an
Alison, be able to field that one, yeah.
Are they audited?
Yes.
No, they're not. I guess that's always sort of an internal process that you know, practice managers need to be looking at to make sure that they've got their current software up to date, to ensure that it's extracting from their computer program to go up to air. So, but there's not an auditing process in place from DHHS as such.
Thanks, Alison.
Yeah.
Thank you, Alison. Okay, so now we're going to cross over to Jenny for our coronavirus update. You can unmute Jenny. Sarah, would you mind unmuting me?
I think I might have just done it.
Yep, there you go. Hi, Jenny.
I'm used to talking to myself, don't worry about it. But thank you for everybody who's given up a Wednesday night, and I'm not really sure what's on TV, but you've given it up to come and talk about what we all love to talk about, immunising and health. So here we are. Thank you so much, guys. Big turnout from Western Vic, which is very, very impressive. We are much bigger than any of the other PHNs I've been involved in this webinar. But obviously we're going to talk about two things. We're going to talk about COVID-19 and where we're at, and we're going to talk a bit about flu, and we're going to talk about flu vaccines specifically, which is, I guess, where all of us, including myself and Kyle, are at the forefront of delivering that. So let's go. Okay, I'm not sure how many of you have seen this incredibly dense daily information about coronavirus that comes out. But I think the most important things to see are the top, which is your total numbers. I believe there has been another death. So this was true as of about lunchtime today. I think we might be up to 103. But I mean, the stats for Victoria are really impressive. We have very few cases. If you have a look right up the top on the curve right up the top there, it showed that really big cluster in March where we all clamped down. And then what it looks like is a very long tail. And people talk a lot about a second wave of coronavirus. I'm not sure that we're going to see two distinct clusters, but rather a very, very long tail. That is not going to overwhelm intensive care units, and none of us want to see the sorts of scenes that were happening in the US and New York in particular, and Italy, where we had to choose who would get a ventilator, and we had body bags piling up inside a hospital. Those numbers are much more manageable in Australia, but it's still a pretty long tail. Let's delve into those a little bit more. Okay, so these are the stats as of today. So right now in Australia, there are 30 Australians in hospital with coronavirus, 5 in intensive care, 3 of those are in Victoria. As of about lunchtime today, there were 15 new cases. That's the same as yesterday. We've just got this super long tail. I'm not sure, you know, Jacinda Ardern has really talked about getting rid of coronavirus altogether. They're not able to get rid of it much either. For so long as we continue to have Australian expats coming home, there's going to be some level of new coronavirus coming to the country, a much smaller amount of community spread where we don't know where it's come from, but they are definitely there. We had no deaths, although I think that was at lunchtime today. I think I did see some stats come in that at about 5 o'clock, I think there was an announcement of another death. I think the numbers at the bottom are really, really important. So the first is the number of cases per million of our population. And we in Australia are at 280. New Zealand is at 312, and we both have 4 deaths per million of population. That is significant because while New Zealand has really unlocked quite hard, actually, compared to us at the moment, they basically went to what they called level 4 shutdown, which is everything shut. There was no takeaway coffee, there was no takeaway restaurants. Literally everybody had to shelter in place and not leave their home without a permit. And yet their death rate has remained the same, and their case rate has remained fairly similar, 312 plays 280. I'm going to give you some other stats for some other countries just to put it into perspective. The cases per million of population in the US is about 5,215, and in Italy is about 3,813. And the deaths per million of population, so ours is 4, in the USA it's 304, and in Italy it's 545. So you can see from those statistics that while we didn't completely shut down our economy, we've done fairly well. The testing numbers are high. I know that some of the benchmark people were only, 2 weeks ago, I think Sarah and Cherie, on our Northern Territory version of this webinar, we're literally at half that. So our testing numbers are increasing, and yet we're not really seeing much moving of the needle in that 2-week period for that very, very long and lumpy tail of coronavirus. And I think we're increasingly realising that we simply cannot test our way out of this pandemic. Okay, this is a super interesting slide, and I'm sorry it is so wordy, but there's some countries in there that I think are particularly of note. These are, we're trying to summarise here the sorts of numbers, the public health response, the tests, and in various countries. So we've already gone through Australia and New Zealand. We've looked a little bit at USA and Italy. There are a couple that I'd like to point out to you. So Sweden is an interesting one. So for anybody who's been following this, Sweden has decided that they were going to go down the route that the UK was initially going down, which was trying to get herd immunity into the country. So they really didn't shut down their country at all. They allowed restaurants and bars to continue. They kept their schools open. They pretty much carried on as normal, although they did close a lot of their borders, except they were allowed free movement of people from Europe and Switzerland. And of course, a lot of people in Europe, that was some of the highest, that was at one point the hotbed of coronavirus. Now, their numbers are not great. As of today, Sweden has 3,412 cases per million population. It is still not as high as Italy, despite Italy having very severe lockdown measures. They are only starting to open up now. But the interesting one is that they have 409 deaths per million of population. That is really quite high. That is higher than the USA. It's not quite as high as Italy, but it's climbing up there. And that has continued to climb. There are some cultural things that if you compare Sweden to Italy are quite interesting. So Swedes, the biggest form of household in Sweden is a single person household. So they do naturally self-isolate in Sweden to a greater extent than they do in Italy. There are very few of these multi-generational family gatherings where people get together, and it's a more reserved culture where there's not a lot of hugging and kissing. Plus there is a lot of faith in public health systems. So if their governments advise people not to go to a beach, you're not going to get a Bondi Beach kind of scenario in Sweden like we would get here and need legislation to slap everybody down and keep them in their own homes. That is very different to Italy. I think I've only been to Italy once, but I remember thinking that if you wanted to find the smoker, you look for the non fumare signs, don't smoke here, and that's where all the smokers will be crowded, and they're all going to go smoking there because in Italy, I reckon they think that their public health infrastructure is completely a pain in the butt and not to be believed. Other ones to watch are, of course, Indonesia, which is our nearest and in some ways our dearest ally. It's a very important community for Australians. Their numbers are really climbing quite high, and they are not doing much testing at all. And it's just one to note. I thought I'd throw in South Korea at the bottom because they have never closed schools. They really don't have particularly high testing levels, despite the fact that when it all first started, their testing levels beat ours hands down. They have opened their borders. They've just got quarantine for people coming from Europe. They have an app with quite a high take-up. They've only had a partial lockdown, and yet their numbers have been quite good. And again, there seems to be, the app seems to be really largely responsible there, and a very high degree of faith in the epidemiologists and in the public health sector. Let's move on. I just thought I'd touch on Victoria because, sorry, but I am so jealous. I'm sitting here in Sydney, and I'm allowed to have 5 people over for dinner. I'm sorry, what's 5? 5 is not, like, what is that? 5 is like, it's 2 couples, right? Because I can't tell a third couple to come over for dinner and not, bring the partner. So I have loved what has just happened yesterday in Victoria, and it just makes so much more sense. I think that rule of 20 and look, I don't need to tell you guys this because this is your state and you are living it, and you guys know a lot better than I do what is going on here. But having been in some ways the most conservative state and having the most severe laws, particularly when it came to schools, and there was quite a bit of conflict between Daniel Andrews and Scott Morrison, I think that in some ways Victoria is now leading the way, and I think I'm really hoping that Gladys has a look at all of this and how Victoria goes. And on the 21st of June, you guys are all going to be allowed to have 50 people in a restaurant, which I'm sure the Restaurant and Catering Association are thrilled about. And you're going to be able to have bars with 50 people, but you've got to have a meal. Again, I don't think there'll be too many bars that are too devastated by that. So this is where we talk about us, because, it is all about us. We are on the front line. And certainly when this first started happening and we saw what was happening to our colleagues, doctors and nurses in the UK, in the US, across Europe, this has been fairly terrifying for our community. And I think we have come together in a way that has been really professional. Nobody wants to dish dirt on teachers because, they do an amazing job, and don't we all know that as we've tried to homeschool our kids, and that's just not been fun. But you certainly have not had nurses either in aged care facilities, in general practice, or in hospitals going out on strike because they don't want to have to go. Nurses have been dogged in their grim determination to put the patients first and to put patient care at the centre of their world, and my hat's off particularly to nurses, also to GPs and to doctors who have just pitched and not bitched, which I think has been really beautiful. But it does leave us with a few questions about how to manage a patient who has respiratory symptoms. We've been told we need to be swabbing absolutely everybody. We also don't have a lot of PPE. I am going to hand over to Alison and Claire a little bit to talk about how this works for you guys in Western Vic. But what do we do if we have a patient who comes into one of our surgeries and reveals respiratory symptoms? Now, I don't know about you guys, but it's been fairly windy up in New South Wales. We've had an absolute epidemic of allergic rhinitis and sinus disease because of the wind and the pollen. What do we do with all of these people? Do we don PPE? Do we not? Are we keeping them away from our practice? Are we telling people don't come here? There are implications for that. There are implications for GPs that are financial. There are therefore implications for nurses who might have some of their practice nurses who might have some of their hours cut, and there's an emotional toll for whichever way we go. And so I guess I thought I'd hand over to the Western Vic PHN girls just to talk us through what you recommend in terms of the management of these patients and how where they go. So maybe Alison, can I start with you?
Sure, but I'm actually going to go Jenny, straight to Claire, because that's her area that she's dealing with. Yeah, from the
awesome. Sorry about
Sorry.
that, Claire. I handed to Alison. I should have handed to you. I'm apologising. Tell everybody, what is your recommendation in terms of the management of patients with respiratory symptoms in Western Vic, PHN area?
So the PHN doesn't have a directive that we sort of, recommend to our community. I think very much it's up to the discretion of the general practice about if they want to be managing patients that have respiratory conditions, and so generally it's up to the discretion of them. So I guess we're fortunate in the Western Victoria region to have a number of specific GP respiratory clinics. So those are, I guess, an alternative if a clinic doesn't want to be, I guess, essentially what it comes down to having to screen someone for COVID because of the breadth of symptoms that now exist for criteria for testing. So they can direct patients to go there, and those sorts of clinics usually have their own booking systems and processes that need to be followed. But we do have a number. We've got 5 currently sitting within the Western Victoria region. So that is an option for practices that don't either have sufficient PPE to be able to perform the task or don't wish to perform the task, then that is an option. But obviously a lot of the larger health services have set up their own respiratory clinics or screening clinics as well. So there seems to be a variety of options available for the communities.
Thanks for that, Claire. So I think one of the problems with having the individual discretion, which has been really across the board, is that it puts us in quite an invidious position, and it means that no 2 patients are going to have the same primary care experience. And that's not to criticise the PHN in Western Vic. You guys are also not getting much feedback in this. It is really up to the individual GP. I work in a 14-doctor practice, and 3 of our doctors are over 65. They are in a very different position to perhaps me in my 50s, and then we've got registrars who are in their 20s and 30s. So it is very different for everybody, and I think it is worth having a practice meeting and deciding together. I think the difficult one is, what do you do if a patient turns up having got through all of your screens and said, no, I don't have a fever, don't have a sore throat, and then comes in and goes, I've got a fever and a sore throat, because they desperately don't want to go to a COVID clinic, because they think that if they go to a COVID clinic, it's like a one-way ticket to the poorhouse. They'll never get out of there, they'll just die. And so I was going to, so the guidelines are that if you do suspect the patient may have COVID, we are meant to mask the patient immediately. We are meant to perform hand hygiene. We are meant to don a full gown, full gloves, the eye protection equipment, and a surgical mask, and it is meant to be done in that order. And then we're meant to do the swabs. Until now, we've been wanting to clear the room and do a full clean. The CDC in Atlanta has, which is the US Center for Disease Control, has come out and said there's really not a lot of evidence for transmission on surfaces. That some of the earlier studies that were done in a lab situation, and that because it's an RNA virus, they're highly unstable and they don't tend to stay for a long time on a surface. I think just everybody's going to need to set their own standards, but it does look like just doing a standard clean that you would do after a kid came in with gastro or somebody came in with a cold. Just to wipe down with your ViraCleanse or whatever you're using is fine, and you certainly don't need to have half an hour between patients if you have a suspected COVID, which was what we were doing in the beginning, and it just became unsustainable. Okay, our first viewer poll. Guys, there are so many of you. I am so excited to get these results in. We've just talked about donning PPE and all of the implications for that. And obviously our first question is, do you have sufficient PPE in your workplace right now? I thought it was interesting, Claire, you were saying that that you haven't had an enormous amount of outreach from local practices saying that you did that they were needing more PPE, even though you guys are supplying it. Is that right?
No, maybe I didn't explain things well. I did say that the PHN specifically only generally has access to surgical masks and occasionally P2 masks. So I guess initially we were, large volumes were being required by practices, but I guess, that varies. Some practices might decide that they don't want to test, so then they don't necessarily have as high demand for those sorts of PPE. And I guess we haven't, as a PHN, been provided with anything much further than masks as well. So we've not had, gowns to deliver to general practices or goggles or any of those additional things.
Yeah, we've certainly had the same where we are in Sydney, and it's been interesting because, the access to gowns has been really problematic, and we're having to reuse goggles and face masks, and we don't really have clear guidelines about the cleaning of those either, although as the new information comes out about the lack of transmissibility via surfaces, that is really quite reassuring. So Cherie, have we got some answers for this one?
Yeah, so 68% said that they have enough PPE in their workplace right now, and 32% said no, they don't have enough.
Okay, well, I think Western Vic's doing better than most other regions of Australia. So another area where you guys are excelling. Let's move on. Okay, this is where we come to your Q&A. So any questions that you have about COVID, because we are going to move on to flu after this. Normally, we are all just literally drowning in flu consultations at this time, and of course they're all being shuffled off to the COVID clinics. So Cherie, do we have many questions at this point?
We've just got one question. When should staff wear PPE?
So at this point, the only reason to wear PPE is if you are actually performing a nasal swab for COVID. So there's no reason to sit all day in PPE. It's going to be a waste of that really precious resource, and it doesn't give you additional protection. There's not a lot of evidence to support that, and in fact initially a lot of GPs were insisting on wearing scrubs, and there's some data that's come out of Italy that suggests that viruses don't really last very well on solid surfaces, but very, very poor adherence to clothing. So there's really, I know that some people are sort of going home and their partners are making them strip down to their underwear in the doorway and put all their clothes in a garbage bag, and they spray it with Glen 20. That's probably no need for that. That's we can just proceed as normal, wear your normal clothes, that's fine. Should we move on? Should we talk about our next exciting topic?
Ginny, there's just one more question.
Oh, sorry, Sarah.
Yeah.
Staff need to wear a mask all day.
What a great question. So just to revise, masks are not for your protection. They are for the protection of the other people in the room with you. And so droplet spread, which is the most important spread in close confines over a prolonged period of time, is how COVID spreads. And it spreads by coughing, sneezing, but there are quite a large number of droplets in just talking. So just conversations, and conversations is what we do. I do wear a mask all day, every day. Even though I have no symptoms, I wouldn't attend work if I had symptoms, but I do that to protect my patients, mainly because my consultations tend to be long. And so I will be with a patient for more than 15 minutes on average. I do have my COVID Safe app on at all times, and my phone is with me in the room. But the purpose of my wearing the mask, as I tell all of my patients, is to protect them. There is no benefit whatsoever for me. I get rosacea on my skin, so I find I'm itchy and irritated. I don't like them. I can't wait to be told to take them off. But until we see zero community spread, I'm not prepared to put my patients at risk, as I would also never be prepared to not have a flu vaccine and again put my patients at risk. But it is all up to you. Okay, let's go through influenza. Aren't we normally literally drowning in influenza? Take a look at these numbers, which I've taken from the Immunisation Coalition website. So The reason I did this was I wanted you to see that from 2018, 2019, 2020, 2018 was a low flu year following our horror year in 2017, but 2019 had a pickup again. And that's unusual to have a pickup so soon after a bad flu year. And yet it happened in 2019. I'm not sure that it is all to do with increased swabbing, although we are doing far more swabbing for sure. So January was looking like 2020 was following on 2019 and looking less like 2018. Again, that's quite unusual. We're expecting a light flu year this year just because we had such a big year last year. Once again, February was looking a lot more like 2019 and less like 2018. And then COVID struck. We all went into lockdown. We started socially isolating, washing our hands, and look at the flu numbers. So in 2019, there were 11,158 cases, but this year there were only 5,569 cases, but still more than there were in 2018 in March. And then have a look at what happened in April. While there were 18,667 cases in 2019, we had a grand total of 305 this year. This is Australia-wide. And the trend has even further exacerbated in May. There were 30,372 cases in 2019 and only 138 in this year, and we're pretty much at the end of May. There have been some different theories, and I was hoping to bounce this off Kyle as well. Obviously, there is a lot of hand washing and social distancing, but we also have closed the borders. And I'm wondering, Kyle, what you think, what contributes to a normal flu season, and why have these numbers been so low? Is it all of that? Is it the high levels of flu vaccine that we've seen, or all of the above?
They're pretty incredible numbers, I reckon. Look at 138 positive
for the whole of May.
May, that's amazing. I reckon most likely multifactorial. I feel as a GP, usually every 2 or 3 weeks, I've got a runny nose and a bit of a cough. But I've been remarkably well for the last 3 months, well, 2 months. We've been vaccinating, I feel like I've vaccinated half of Victoria in the last month against influenza, so probably that would play a role, but definitely the self-isolation and the social distancing stuff. Yeah.
So I've had another theory as well, which is that as everybody who has any respiratory symptoms whatsoever, including the ILI, the influenza-like illness symptoms, has taken themselves off to a COVID clinic rather than going to their GP, there are no swabs happening for flu. Because when you go to a COVID clinic, it's either do you have COVID or do you not have COVID? And in which case, if what they're presenting with is influenza A or influenza B, we are going to be missing them, because I have not been aware. I'm aware that if I do a flu swab, an automatic COVID swab is added and COVID test is added to my flu swab, but I'm not aware of the inverse happening, that if somebody goes to a COVID clinic presenting febrile with a sore throat, aches and pains, are they going to have a swab for flu, or are they just going to have a swab for COVID? It's all food for thought, but these are very interesting numbers.
Yeah.
Okay, just a reminder of the flu vaccine for 2020, that we actually did change both of the flu A strains and the flu, one of the 2 flu B strains. So this is quite a big change to the 2019. We don't normally change 3 strains. Whether or not it's a good match, we're almost not going to know, because we don't have enough flu strains around to know whether it's a good match or not. So you'd have to think that this combination will make its way up to the Northern Hemisphere. And again, if the same pattern happens in the Northern Hemisphere, where they're either not swabbing for flu or people are just not getting it, I imagine there will be 0 changes to next year. But let's wait and see. Just a reminder, I mean, man, what am I telling you guys for? You should be telling me this. This is just a reminder of which flu vaccine to use for who. A couple just to point out there, the ones with the double asterisk there, that means they are funded, but only for Aboriginal and Torres Strait Islander patients. Just a reminder that you don't use the wrong one. The 65 and over is interesting. They're all funded except for the Influvac Tetra. But really, can we not use those? That's what's happening when our patients over 65 are going to pharmacies. I think it's driving every single one of us here nuts when someone over 65 is getting a standard flu vaccine. In 2017, we had only a 10% seroconversion rate, which is what was the urgency to get our adjuvanted or high dose flu vaccines up. So they came in 2018. We had adjuvanted and high-dose flu vaccines. We've ended up with the adjuvanted flu vaccine, the Fluad Quad, which is approved for all over 65s. That is simply not available through pharmacies. And we really need to be making sure that our over 65s who do have immunosenescence or a poorer response to a vaccine stimulus in terms of that antibody response, we need them to be getting that adjuvanted vaccine with the higher efficacy for our over 65s. Otherwise, you can see which ones are up to 3, 3 to 5s, and the rest of us. Another poll. This is really interesting. So I think we kind of know the answers because we've been seeing the numbers. Kyle's immunised half of Victoria. I'm wondering if between the rest of you you've done the other half. Have you guys noticed an increased willingness to get the flu vaccine? I'm going to loop back to COVID here while I'm waiting for you guys to fill this poll out. And the reason is that there's some data that has come out from the US and from France where less than 50% of parents surveyed are intending to have their children vaccinated against coronavirus should a vaccine become available. And it's really quite concerning data. We have had those protests, particularly in Melbourne, that were the anti-vax protests. Those people tended to coalesce around some of the more wild Pete Evans ideas around 5G towers transmitting coronavirus, but at the same time coronavirus being a hoax, which is an interesting combination. But they are very strongly anti-vaccination. And while I'd love to think that they're a lunatic fringe, if Australians, like indications would suggest, US and French parents refuse to get coronavirus vaccines, then achieving herd immunity will be quite difficult, and that long tail will continue. And it's probably worth us having a chat as a group about how we talk about the coronavirus vaccine to prepare our patients for what is coming. As you know, Melbourne is the site of the first Novavax vaccine in humans, and that is happening right now. We are really, my fellow board members on the Immunisation Coalition who are working on that particular vaccine are very confident that there are 20 human vaccine trials in place now. There are 70 vaccines under development. We will have vaccines to coronavirus, and they'll probably be around at some point next year. It is really critical that we start to discuss this with our patients, because if we don't want to be locked down forever, we need to get widespread take-up. Yes, interesting. So 97% of Western Vic providers are seeing that improved take-up, and that's certainly borne out by the numbers and access to flu vaccine. I really, really hope that continues into the coronavirus vaccine, if and when we get it. Next poll. Have you run out of flu vaccine this year? This has been a really interesting question for us to ask various members of the PHNs that have been dialing in. It's a really fraught problem, because our patients who cannot get flu vaccine often become quite distressed, and their distress can be fed back into our reception staff, to our nurses and to our doctors. It doesn't always bring the best out in people. Out of interest, I think the story is that actually our federal government did procure 14 million flu vaccines, and that included 4 million Fluad Quad, which is the over 65 vaccine. Now, if you look at those numbers, what has been distributed should have been sufficient to not only supply everybody who wants a vaccine, but the vast majority of those who are eligible for government vaccines. and yet it seems that it looks like a lumpy supply issue. Let's have a look at the poll results. Yeah, only 65%. Okay, I'm taking notes. It does look like it is an issue of lumpy supply, because if you just look at the sheer doses that are out in the community, there's enough. It's not like the government under-procured, but of course they went out and subsequently procured further 2 million doses of government vaccine that I believe is hitting general practices and vaccination clinics by June, which will be really important for some of our pregnant patients who perhaps didn't qualify in March and April when we were doing the bulk of our vaccinating, or April mainly, when we're doing the bulk of our vaccination. They will be really important, but it's just an interesting note that we do have enough. It shouldn't be an issue. Certainly some areas have said that the pharmacists were procuring all of the private vaccine. That's a shame, but again, we've just got to get our practice managers out there putting their hands up and buying it if we think there's a demand there, because otherwise the pharmacies will buy it all. I did want to quickly touch on the revaccination debate. We vaccinated early this year. If you remember last year, the government vaccine was held out until the 1st of May. And the reason was that we had in 2017, we had a very late flu season. And in fact, it peaked in September, which is unusual. And so they, given that there is natural immunosenescence amongst all of us, not just the elderly, they wanted to delay the flu vaccine so that we'd cover the tail of the flu season around October. And given that 6 months is what we can expect in terms of coverage from an average flu vaccine, that was the point. However, the fear was from the federal government and from its advisors that if you got a combination of coronavirus or COVID-19 with influenza, that was a particularly nasty combination and increased your risk of requiring ventilation, of requiring ICU beds, and of, unfortunately, of death and permanent lung disease. So as a result, we were encouraged to get our flu vaccine at the peak of COVID-19. And that prompted an article that I saw and flipped about, which came from the RACGP, that basically said everybody was going to need a second vaccine later in 2020. They did retract it, but just a reminder, if anybody didn't see that retraction, ATAGI says that revaccination later in the year is not routinely recommended. It is not funded by the government. That would always be a private flu vaccine for your second one. There might be some circumstances, such as travel, irrelevant to us now, or pregnancy. So if you had a flu vaccine because you were asthmatic at 30 in April and then got pregnant again in September, of course we would do a second flu vaccine during your pregnancy. But other than that, we are not recommending a second flu vaccine, and we're certainly not passing that cost on to our patients. And now over to you guys. We are able to answer your questions. There's myself, there's Kyle, there's Cherie, there's Alison, there's Claire, there's all of us who can answer your questions. So bring them on. Sarah, do we have some already?
We have a lot. So I will let Cherie start with the first few, and then I'll jump in with a couple at the end.
Okay.
Okay, so the first couple of questions were in relation to, and I think you've covered them for us, Jenny, just that pharmacists are telling patients that they will need 2 flu vaccines this year, but you've just clarified that for us, that it's not being recommended, that we don't need the 2 flu vaccines.
Very commercial of them, but not required.
Yep. And why did the recommendations from the Federal Health versus Vic Health Fluad Quad over 65 differ? For over 65s differ? Did
they differ? Kyle, did you see a difference there, or Claire? I don't think so. I mean, I think there's been a fairly consistent message since 2018 when we started getting the different flu vaccines for the over 65s. It's been fairly clear that is the flu vaccine of choice, and we don't do 2 of the other, we do 1. If you ran out of flu vaccine and had no access to Fluad Quad whatsoever, of course, a standard flu vaccine would be better than nothing. However, that just should not be the case. There is enough Fluad Quad to go around. If you just look at the sheer numbers, the government procurement system has given enough to everybody. It maybe put them on hold for a week or two and ring around, but you should be able to get some.
Okay. And can you use a government-funded vax for a private patient, and what are the repercussions if the clinic does so?
So we've all done it, run into the flu fridge. I don't know about you guys, but I've got like 18 boxes of flu vaccine. I forget which one's which, and you all of a sudden pull out the wrong one. You've got millions of patients there, and all of a sudden, boom, in has gone the private when it should have been a public, or vice versa. I just make notes about it and I make good at the end of the day. So you're not going to get audited. I've never heard of a vaccine audit being given before, but I think what's important to do is just to do the right thing by the government. So if you've given a government one to a private flu vaccine person, the next, government person who comes in, give them a private one, and it'll all even out. Kyle, do you agree? I mean, I've certainly made that mistake already this year multiple times.
Yeah, it's a tricky one. There's so many flu vaccinations in the fridge. Yep, we keep note and then we replace them as required.
Fantastic. Jennifer's made a comment saying that they've had limited delivery of Fluad Quad each time, and so now they have run out. So I think, Jenny, you've responded to that in that if there is absolutely no chance of you getting Fluad Quad, then at least get something into that individual's arm for sure. Mm-hmm. And so further to that, the question is around if an over 65 has been given a quadrivalent vaccine, should they receive?
So there's no consensus on this because we don't have really good studies of what happens when you give a standard quad vaccine and then follow it up with an adjuvanted vaccine. We're not aware of any excess adverse events, so no more than we would expect from a standard adjuvanted vaccine. So my recommendation would be, yes, if they've gone to the pharmacy and got and paid for a $25 flu vaccine that was not appropriate, I would follow it up with an appropriate vaccine. I think one of the other situations that's coming up for us, because I think with such a low flu season, you can play for time and say, hey, give me a month. There's another batch of flu vaccines coming. We're nearly in June now. There's another round coming in. Let's just wait and see. The problem comes when they want to visit their husband or wife in the nursing home and they are not allowed in without a flu vaccine. That is a very difficult situation for everybody, and I completely sympathise with people who just want to see their loved one. Get the flu vaccine and we'll deal with it later.
And so then if they have had the QIV vaccine, how long before they should get the Fluad Quads?
So the issue with the QIV is not that it's ineffective, it's just that it doesn't last very long at all, but you probably do have a good 4 weeks of coverage. So it's not like different strains are covered or that you won't, the QIV, the standard QIV just won't take. That's not it at all. It's just within a month to 6 weeks, you might see immunity waning. So I would push it out as long as you can. So I'd wait for 4 weeks to at least extract some value from that first vaccine that you gave.
Fantastic.
Or that was given. Yeah.
Lovely. Thank you. So Jenny's just made a comment saying that last year she had 7 objectors on the staff for flu vaccine, whereas this year 100% have been vaccinated.
Well, there are big groups within who want to make flu vaccination compulsory for staff. We do have that policy in our practice. I think that we have a number of vulnerable patients who we care for and for whom flu for them can be fatal. And while flu for us might feel terrible, if our flu, we know that we are highly contagious with influenza for the 24 hours prior to the development of any symptoms whatsoever, and were any of us to infect an elderly or immunocompromised patient who subsequently ended up in intensive care and then dying, I think we need to think about how we would feel about that. In my practice, we are absolutely strong that it is mandatory and it's not optional. There are practically no contraindications to a flu vaccine. Previous Guillain-Barré and a known anaphylactic reaction. Egg allergy is not an excuse, and the flu vaccine always makes me sick is not an excuse. We have, as healthcare providers, a very strong duty of care to the people who we see in very close confines. Both doctors and nurses are up close and in very close confines with our patients. And I feel very strongly about that. I'd be really interested to see how Claire and Alison feel about that, and the other participants on this dial-in feel about that. I've been involved in some of the WHO work where we were trying to get it up. It's just not been possible to get it up as a policy in Australia for any hospital or any area health network, which I think is a real shame.
Thanks for that, Jenny. So there's been a couple of comments around initial supply was patchy, but it's only private vaccines that are out of stock in the region now. The government vaccines are currently in good supply. So I'd suggest if you don't have vaccine, then you maybe need to contact public health. The next question is around, and Community Health has said that they received vaccine very late, much later than pharmacists, and that some people have had to go to the pharmacy to try buying vaccine. In regards to children with no junior vaccinations, do they still require the 2 full-strength doses 1 month apart? So I'm assuming that question is referring to children under the age of 9 for the first year that they have received vaccine.
Correct. So it's look, Sarah, you just said it. They only ever need 2 1 month apart for the first time that they get a flu vaccine. I think the one that's tricky is a kid gets a flu vaccine at the age of 2, they get 2 a month apart and then don't represent until they're now 7. In theory, they have still had those 2 vaccines at age 2 and we still only need to give 1. Diane, your cat is beautiful. I'm looking at your cat who's sitting behind you and just making me smile. Gorgeous pussycat. Sorry, I'm a cat person.
There's also been a comment saying, so there's a bit of chat around the supply now of Fluad Quad, saying that they're not able to be ordered in Victoria, that supply has been exhausted and no further supply will be available. I don't know if you're able to comment on that, Alison, or if anyone else, Kyle, if you've heard that through the grapevine.
Immunisation, so Paul, oh God, I've gone blank on his name, our chair. Anyway, it is coming. We are getting a whole new, we've procured 2 million more doses. They are coming, so just hold out. It's, as you can see, the flu numbers are not big. It doesn't really matter. If you're going to wait another week or 2 for it, it's fine. Alison, your thoughts?
Yeah, I think part of the problem with the supply issue down here was around the delivery. I mean, it was just, when we hit that peak around mid-March, and everyone was just phoning the clinics and everyone was wanting it all at once. And then particularly OneLink had obviously, like everywhere else, everything just got slowed up with the whole social distancing and putting all those things into place. So there were some supply issues, and I don't think it was essentially that the vaccine wasn't there. It was around getting the vaccine out quick enough, and just the demand was so high, and I think that has to some degree it's eased up, I guess. Speaking to a few of the local clinics today, yeah, I think it is starting to ease up.
Fantastic. So maybe we can take that offline and see what we can find out and send it out to participants. You guys are going crazy with the questions. A 65-year-old who is immunosuppressed, are they better to have 1 Fluad Quad or 2 QIV 1 month gap?
1 Fluad Quad.
Thank you. And evidence of blunting, if they've had a quad, then Fluad Quad?
Blunting?
Yeah. So having had a Fluad Fluad Quad first. No, having had a QIV vaccine, is there any evidence of blunting if they then have a second dose?
It's in its infancy. We still there's just still not enough evidence that having a second dose confers benefit. And there were a couple of studies that came out in 2017 suggesting maybe an increase in adverse reactions with a second dose. There's just no benefit from it. We're not recommending. Now, if studies change, that will change and the advice will change, and you can bet that Australia will be first with the new guidelines, and they do change regularly, but right now it's the fluad quad, or the adjuvanted vaccine for the over 65s, and the standard quad for everyone else.
There has been one question around why is there no state or national system with barcoding vaccines to check supply? That's a bit of a tricky one.
Well, they've got a number of suppliers, and so they do. I mean, actually, a lot of it is stockpiled in Queensland before it gets distributed, and it goes there. And there is actually barcoding that happens at the warehouse level before it's distributed to various states, and then from there to the various PHUs and out from there.
Fantastic. And there's also been a couple of participants tonight saying that their practices have a 100% vaccine policy. Or
yes,
so that's fantastic.
Love your work. Love it.
Excellent. I think we've pretty much got through all of them. So on that note, there is a couple of questions around pneumococcal vaccine. I'm actually just going to park those until we've heard from Kyle.
Okay, Kyle.
Thank you, Cherie.
Hi everybody, my name's Kyle. I'm a GP and I work in Melbourne, actually in Brunswick. So I've been watching Lygon Street get busier and busier over the last week or so. There was no traffic 2 weeks ago, which was fantastic. You could hear the birds singing. I'm going to talk about pneumococcal disease and the vaccinations that we have available for pneumococcal, the current guidelines for pneumococcal vaccination, as well as potential changes that are coming up. So pneumococcal disease stems from Streptococcus pneumoniae, which is a bacteria that's commonly found in the upper respiratory tract of healthy people and unwell people. Pneumococci can cause infections really through two pathways. The first pathway can be overgrowth of normal commensal pneumococci, well not normal but commensal streptococcus, or it can be bacteria that is found in sterile sites, including the lungs, which causes pneumonia, or the meninges, which causes meningitis, or the bloodstream, which causes bacteremia. Pneumococcal causes pneumonia, which is pneumococcal main invasive pneumococcal disease in adults is pneumonia, and in kids it's bacteremia or septicemia. There's two vaccinations that are available for pneumococcal bacteria. There's Prevnar and there's Pneumovax 23. So Prevnar is a conjugated vaccination, which means it's a sugar molecule that's connected to a protein, diphtheria protein, which basically allows a greater immune response to the pneumococcal bacteria. Prevnar 13 has two different dose schedules. Sorry, Prevnar 13 covers 13 serotypes of pneumococci. There's two separate schedules. There's a 3-dose schedule at 2 months, 4 months, and 12 months. Or there's a 4-dose schedule which conveys an extra dose for at-risk children. There's the second vaccination is the Pneumovax 23. And the Pneumovax 23 vaccination is what we call a polysaccharide vaccine, which basically is a sugar molecule. So sugar molecule polysaccharide vaccinations give a slightly less robust immune response to the pneumococcal bacteria. So the Pneumovax 23 current schedule is quite confusing. There's multiple levels of dosing that is dependent on a range of things. It's dependent on age, it's dependent on comorbidities, it's dependent on when you had the last Pneumovax 23 vaccination. It's dependent on particular demographic, so cultural background. It's quite confusing. So, and the next slide should exemplify. So there's a lot of text on that slide, and that's kind of only a small component of the dosing recommendations for Pneumovax 23. So I guess at-risk people are categorised into two categories, Category A and Category B. Category A risk is associated primarily with, well, primary immunocompromised conditions, things like asplenia, things like immunosuppression therapy, solid organ transplant, all that kind of thing. Category B conditions are conditions that lead to becoming immunocompromised, but not primary immunocompromising conditions. So the next slide. So the Pneumovax 23 vaccination currently is recommended for, has different dosing for medically at-risk population, which is then further broken down into Indigenous people, non-Indigenous people, dependent on their medical risk. It's very, very confusing currently. One of the takeaways that I've realised with the pneumococcal vaccination is I'm never really sure who should have a Pneumovax 23 vaccination and when they should have it until I check. So every new diagnosis, every new diagnosis of a chronic medical condition, you should assess that individual for eligibility for a Pneumovax 23. Yeah, next slide. Non-medically risk people are separated into two demographics, so Indigenous and non-Indigenous, and then again by age. So Indigenous people greater than 50 years of age get 2 doses that are separated by 5 years. Non-Indigenous people greater than 65 years of age get a single dose until their risk changes and then their dosing regime changes. So Pneumovax viewer poll. So who should receive the pneumococcal vaccination? Just covered my text. If they're not considered medically at risk people. And go.
So Kyle, waiting for that poll to go through. We might, if it's okay, I've got a couple of questions for you here. Is there a lack of Pneumovax 23?
There is, yes. So I'm not actually sure what the current stock is, potentially PHN. So Alison might be able to answer that better than me. In Victoria, I think there's a likely to be low stock until mid to late May, unless that's changed.
Alison,
Yeah.
do you have any thoughts on that?
I haven't got any additional information to add to that, Kyle. Actually, you probably know more about the supply issue more than I do at the moment.
It's funny, in the GP world, we're kind of a little bit insulated. So I know that there's lots in my fridge, but I don't know what everybody else's fridge looks like.
Yeah, yeah.
Yeah, which I guess is a good reminder that staying up to date with PHN relationships is, you know, a good move in terms of primary healthcare.
Yeah.
So you don't get caught short.
There's definitely a national shortage. And I think the discussion has been that we need to prioritise who we're giving our Pneumovax 23 to. So making sure that we're considering, you know, those at most vulnerable or highest risk, and administering to those. It does seem that some practices have vaccine, a lot don't, but we actually don't know when it will be available.
And there's been a bit of a run recently of people who don't qualify for the PBS Pneumovax 23 vaccination. I've had quite a few people come into my clinic on the back of an APC specialist where Dr. Norman Swan recommended everybody get Pneumovax 23 dose. I don't know whether that's affected supply. Hasn't really affected my fridge, but lots of people getting a dose of Pneumovax 23.
I think to a lot of patients are hearing it around the traps, and so they're actually coming in. Certainly in our clinic, we've got more patients coming in requesting that haven't had a Pneumovax vaccine and are over the age of 65. So we operate a walk-in clinic, and so we do, a lot of the patients are not our regular patients, and certainly we've got an increase in requests for the vaccine. Lots of practices are coming in saying they just have no supply. They've put orders in but told there is no ETA on vaccine. Practices saying they've got waiting lists happening.
Yeah, right. Wow.
So it seems like you guys in your region are really struggling in regards to vaccine.
Okay.
There is your results.
The results are in, Kyle.
Fantastic. I actually selected both of those top two on my personal computer. I selected both of those top two tick boxes. So I think that I might have got that question wrong, to tell you the truth. I should have clicked all of the above instead of both of the other options. Okay. So there's some proposed changes to the pneumococcal vaccination that don't have a definitive date yet. Ginny might have some more idea about the date of proposed changes. No, she's shaking her head. No? Okay. So basically the proposed changes resulting from Pharmaceutical Benefits Advisory Committee in 2019, got advice that current recommendations were fairly complex and potentially should be streamlined. The recommendations involve changing Category A and Category B definitions to be a single high-risk pneumococcal disease condition. I think that would make it way easier. So the new recommendations is this table. And I'm not sure if anybody's had a look on the Australian Immunisation Register, Australian Immunisation Handbook recommendations for who is eligible for a Pneumovax 23 vaccination, but it is massive and condensed down into a 3-columned table is fantastic. So the new recommendations will separate people based on age, based on how many doses they've had, and based on their indigenous status. It'll be a 1-dose or a 3-dose regime, with a single dose of Prevnar 13 for all groups, and then 2 Pneumovax 23 vaccinations separated by 2 months, and then 5 to 10 years. So the take-home message is this. Currently, the Pneumovax 23 recommendations are quite complex. The selection for candidates to have a funded Pneumovax 23 vaccination should be assessed for every single person when they have a newly diagnosed comorbidity, chronic medical issue, at particular age points. 65 years currently, likely to change to 70 years in the future. Currently, we assess patients for Category A and Category B medical conditions, which can be found in the Australian Immunisation Handbook. There's also a tool called the PneumoSmart vaccination tool, which is awesome. But the PneumoSmart vaccination tool is only recently, I've only recently learnt about that. It basically does all the work for you. I can't believe that I haven't been using it for years and years. You plug in the person's, it's kind of similar to the cardiovascular disease calculator. You plug in the person's demographic online. Oh, sorry, you plug in the person's risk factors, and it basically pops up with yes or no and the dosing regime. The likely changes to the pneumococcal schedule is upcoming, but nobody really knows when. I guess another reason to stay in contact with PHN, because I know as a GP, I'm often the last person to find out about changes. Often it'll be when somebody walks into the clinic and says, oh, can I get this? It's what I should be getting. I like to think that I stay up to date with everything, but I don't think that's the case often. And the PHN is really good for that kind of information dissemination, I think. Yeah, Pneumovax 23 vaccinations currently in short supply, possibly until mid to late May. There you go. And we should be prioritising in high-risk individuals who haven't had a dose yet. Yeah, that's pretty much that. And our questions done.
Yeah, so we've had a couple more questions come through for you, Kyle. Drive-through vaccines, is it okay?
Has anybody given a drive-through vaccination? I've given quite a few. I've given them on Lygon Street in Brunswick, which is quite busy. I think, yeah, it's totally okay. Vaccinating, I mean, flu vaccinations can be a bit difficult to drive through when there's 2 kids under the age of 5 in the car. They're difficult enough to wrestle in the clinic room, let alone in a car where you're reaching in there with a needle. So maybe the answer would be yes, but with sensible selection of candidates.
Okay.
Maybe just to add to that, you've got to do your own risk assessment with your own clinics. Certainly, you need to consider what your policies and procedures are saying. And like Kyle's saying, if you do that risk assessment and decide what's right, you also need to make sure that your patients aren't going to drive off. They still need to stay for the 15 minutes, and also that you actually have processes in place that should someone have a reaction to the vaccine, that you're actually able to access them. So if it's something that you're considering in your practice, you need to make sure that you have put policies and procedures in place and completed that risk assessment. Not just that we said you can do it.
And the next question that we've got for you, Kyle, should staff be wearing PPE when vaccinating?
That's a good question. I think Jeannie might disagree with me when I say this, but yeah, I reckon so. Yes, in our clinic we wear gloves, and that's all. I think in the era of COVID, I guess a positive contact is, within 1.5 meters of somebody for longer than 15 minutes. If that's the case, then you would be wearing a face mask also. Yeah, so standard PPE for vaccinations currently, which is gloves.
So further to that question, someone's just responded saying, do you change gloves between patients, and why are you wearing gloves as opposed to doing appropriate hand washing between patients?
Yep. So you wear gloves in case you needle stick yourself, basically. It provides a protective layer from needle stick injury for the person giving the vaccination. Yep. You change gloves. You change gloves. So that's an excellent question. I think that the answer is yes, you change gloves currently because you're likely to be coming in contact with people. I guess hand washing is an alternative, but I wear gloves when I vaccinate somebody so that I don't needle stick myself. Well, in case I needle stick myself, I have added protection.
A couple more questions that we've got that I might open it up to the panel now, because some of these are quite generic. So someone has asked in regards to administration of Pneumovax vaccine, should it be given in a separate limb if giving Zostavax and flu vaccine at the same time? Would you give the Pneumovax 23 and the flu in the one arm? Sorry, I got that wrong. Would you give the Zostavax and the flu in one arm and the Pneumovax 23 in the other? I've always given the live vaccine on its own. Does the panel want to comment on administration, or even Alison, what the recommendations are in your region? Kyle?
So the general recommendation is Pneumovax 23 in a separate limb. I guess if you're giving multiple vaccinations at the same time, I would check, and I would check concurrent vaccination recommendations, from the product manual.
Anyone else like to comment? Alison, have you got recommendations locally?
Not locally. Look, we refer everything back to through the immunisation handbook. So we're always encouraging people to check that. They can always ring the department if they're unsure. Any vaccine that's given in the same limb needs to be spaced by the 2.5 centimetres apart.
Fantastic, thank you. Another question around home visits for vaccination. Ginny, do you want to maybe comment on that? Should we be doing, or can we be doing home visits for patients, maybe more vulnerable patients? Or how do we implement clinic to protect our most vulnerable?
So it certainly can be done. As long as you can ensure the cold chain of your vaccination, that you've got access to wash your hands. I just might point out that the Australian Immunisation Handbook does not recommend the routine use of gloves for the administration of vaccines unless you have sores on your hands or you think that you are at risk of a blood-borne disease, which hopefully is not a common event with an intramuscular injection. So as long as you have the appropriate equipment, a sharps box, so you don't want to be resheathing a needle. So if you have a little portable sharps box, there's no reason why you can't. Just make sure that you are documenting the vaccine and the dose in the patient's files, even if you just put the little sticker on their consent form. I'm not sure if you guys consent everybody, but make sure that you just note the vaccine dose. There's no reason not to do it.
And similarly, if you are providing vaccines in a patient's home, you do need to be a nurse immuniser if you are doing it without a doctor's order or a doctor present. So making sure that you're working under a health management protocol. A nurse who is not a nurse immuniser cannot go and administer without a doctor on site. So there's a question around community nurses doing vaccinations in clients' home. Certainly if you're a nurse immuniser, that's not an issue, but just make sure that you're working under the policy and procedure and the orders of the organisation that you're employed with. We've got so many questions tonight. if an individual under 65 years of age purchased a pneumococcal 23 privately, Pneumovax 23 privately, what would the recommendations be once they turn 65? So if they've had it before the age of 65, do they need to be revaccinated at 65 years of age?
It would depend on I would have to check the immunisation. So I would look at the immunisation handbook, or I'd go to the Pneumovax tool online. So it would depend. And this is without checking those particular guidelines, because it's quite a complex dosing regime. It would depend on their demographic. It would depend on their comorbidities. So generally dosing separated by 5 to 10 years. So the government would subsidise a Pneumovax 23 vaccination at age 65, is my understanding, but I'd have to have a look at I would have to check the current recommendations.
Do you have anything to add to that, Jenny?
Not really. I think that's covered it.
Cool. We've had a couple of people comment on Zostavax and Pneumovax. They thought that it's not recommended to be given on the same session.
Yep, I know, I could see that. I have to check Zostavax every time. It's one of the ones that I'm worried about giving in the wrong setting. So I look at the guidelines before I give Zostavax, no matter how many times I give it.
So in regards to administering both in separate limbs on the same visit, any comment, Ginny?
No, I tend to look it up as well. So I don't have anything to add.
What we might do is provide the recommendations to the group after this.
I don't think there's an issue, actually.
My understanding is that as long as they're administered on the same day in separate limbs, then that's okay. But we will forward those out post-workshop. Someone's made a comment around making sure you take your adrenaline with you for a home visit. Well, you should always have adrenaline available and make sure that it is in date. And that's obviously part of your risk assessment and your planning if you're doing home vaccinations. Can I give an NIP Pneumovax under 65 for a person with a chronic disease? Depends on that chronic disease.
Yep, if it's category A or category B, and it depends on if they're Indigenous or non-Indigenous, and it depends on if they've had a previous dose.
Yeah.
So, good question. Nobody knows till you've checked.
There's a lot of people commenting on the recommendations from the manufacturer for Zostavax. It can be given on the same day. The handbook says yes, however, the PI states separately, but ATAGI says that we can give it. So there is your recommendation around Pneumovax and Zostavax on the same day.
Excellent.
Okay, so again, like both Kyle and Ginny have said, just make sure you're going to the handbook and checking it, but certainly on the same day, separate limbs.
And I think, Sarah, it's, and correct me if I'm wrong, but the handbook overrides the PI. And that's, that's just sort of something that we should, I guess, as immunisers always remember.
One more question regarding Zostavax in regards to those who have had a history of cancer and chemotherapy agents, as well as hormonal treatments. Not sure what the question there is, Tegan. No, not coming through. Is it contraindicated? So is it contraindicated regarding Zoster in regards to those who have had a history of cancer or chemotherapy agents, as well as hormonal treatments?
Well, hormonal treatments are not an issue.
But if you're currently immunosuppressed, you can't have a Zostavax.
But I think in terms of the corticosteroids, it's more than 20 milligrams per kilogram per day. So it's reasonably high dose steroids.
Thank you. So if you are giving Zostavax in your practice, you should make sure that you have the appropriate consent form too. It's not your generic consent form for immunisation. There is actually a Zostavax flowchart and consent form that actually covers off all these questions that we have here. And certainly in our practice, we have the consent form signed, in particular if patients are getting Zostavax. So making sure that your policies and procedures in your organisation actually cover exactly what the handbook is suggesting. For those of you that have completed the immunisation course through the benchmark group, we do have that, an example of that consent form available to you in your resources. So maybe that's something that we may even look at providing to the event tonight, if that's okay with you guys, Alison, locally. We can
absolutely. That would be great, Sarah.
And provide that as well. Does the handbook override the PI from an insurance point of view? Handbook always overrides everything. So the Australian Immunisation Handbook is the Bible when it comes to immunisation. And I think I've got the backing of the GPs in saying that as well.
Absolutely.
No matter what the PI says, it's the handbook. And so I think it was Claire that mentioned earlier, if you have a hard copy of the handbook on any desks in your clinic, in your community health setting, wherever you are practicing immunisation, you need to get rid of them. They are a doorstop. That is it. The risk
put them in the fire, Sarah. We're down here in the southwest Victoria. They'll make a great tool to start our little wood heaters with.
There you go. I am in warm Queensland, so
get rid of them.
There you go. Alison saying you must get rid of them, and you can download a link onto your desktops, but also the Australian Immunisation Handbook now has an app. So if you've not downloaded the app from your app store, or sorry, I'm an Apple user, is it the Google store or whatever that one is, then you should be downloading it because it is fantastic. It's the go-to 24/7 for everything immunisation. So yes, it does override any PI statement that you get for vaccines.
And I guess to use.
Sorry?
It's so easy to use. It's so user-friendly.
It is.
It is.
Probably just to add to that, Sarah, if clinics were, wanted something in writing, they can just email the department to get that information back, and they can put it in as part of their policies as well.
Fantastic. And then maybe one last question, because I've just realised the time. Sorry, Cherie. Someone has just asked if you need to complete an immunisation course before giving an immunisation as an RN working in a clinic. I'm probably happy to respond to that, and maybe Alison might want to pipe in here. If you are administering immunisations in community, then yes, you need to be a certified nurse immuniser. If you are working in a general practice, so currently in Victoria, you must have a doctor's order to administer vaccine in a general practice as an RN or an EN. Is it part of your scope of practice? So if you have never administered a vaccine, I'd probably question whether it's in your scope of practice to do so. And what is the policy and procedure within your organisation? So I can't say in black and white there is something written that says you must have completed a course, but it's like anything we do, anything that we administer or any procedure that we conduct as a nurse, we must ensure that we have the appropriate knowledge, skills and competency to do that. And so if you have never been deemed competent in a task, then you need to reconsider it. Someone said GPs need to do an immunisation course. That varies. That varies on the GPs that you're working with. Some GPs are fantastic. So, it's like everything, as well as wound care. So, Alison, I don't know if you want to comment on that for your region.
No, that's correct, Sarah. Yeah.
Fantastic. So yeah, you need to assess your scope of practice, and like all of the tasks that we do and under our APRA registration, you need to make sure that you are keeping up to date with those skills and knowledge and ensuring that you're doing your appropriate CPD annually to maintain those skills. So it's not a black and white answer, I'm sorry, but you need to make sure that you're assessing it. There needs to be a Medicare item number for nurse immunisers. That's a whole nother debate. I might hand back to you, Cherie, for some closing comments.
Yeah, so for our flu and immunisation programs, for clinicians for the 2020 clinical practice unit, we're offering the discounted $45 per student, delivered completely online. And for the admin support unit, it's $35 delivered online. And Sarah has also asked me to remind everybody that for our Victorian delivery, course delivery, face-to-face workshops, we will be getting out to you soon as restrictions ease a little further. We are coming out to you soon. So watch this space for those. Definitely, we'll be getting out to you soon. So you'll hear from us very soon in relation to those. And I'd just like to thank our sponsors. And thank you everybody for attending this evening. It was lovely to have you all on board. And also, I think there will be a feedback at the end of tonight's session. So we'd love to hear from you. And thank you all for participating, and you'll get your certificate once you've completed your feedback. And thank you to our speakers. It was great to hear from you all. Yeah, thank you, Alison, and thank you, Claire. Thanks, Jenny, and thanks, Sarah too, and Kyle. It was great to hear from you all.
Thanks all.
Good night, everyone.
Good night.
See ya.
Thank you. Have a good night.
Thanks, everyone.